So this is going to be a quick one on menopause and hormone replacement therapy. Hormone replacement therapy is when you give a woman hormones after she stops producing it herself. So average age of menopause in the United States is about 50 or 51. As the woman starts getting that, she'll start having hot flushes or flashes, depending on how you want to say it, trouble sleeping, vaginal dryness, and really the big thing is when her periods stop. Um, Obviously, one can be perimenopausal for as much as 10 years before one actually becomes menopausal, but it can be a very interesting and challenging issue. And some women have lots of symptoms and some have very few. So when you have a woman who has lots of symptoms, well, what do you do? Well, we usually will use either estrogen or a combination of estrogen and progestin. And so estrogen is fine if a woman doesn't have a uterus, because really the only major risk factor here is endometrial cancer, although there are some risk factors as far as heart and other. But if you do have a woman who has a uterus, you're going to have to use a progesterone preparation. So estrogen is the gold standard for menopause relief symptoms, especially hot flushes or hot flashes or flushes. Obviously, if a woman's got breast cancer, especially if it's estrogen sensitive, has had a stroke or has coronary heart disease, you're not going to use it. But for healthy women, the risk profile is actually pretty low, and it's always that balance between the severity of the symptoms and what little risk there might be. So if you have a woman who has an endometrium, you have to be very careful because the endometrial cancer has been known to develop pretty quickly. And if a woman has a hysterectomy, has had a hysterectomy, then you should be all set. Hysterectomy, a total hysterectomy in my world means removal of the whole uterus. Years ago, back in the 1960s, they used to leave the cervix, and believe it or not, over the past 8 or 10 years, we've started doing that again, just because there is a feeling that we can keep the pelvis from collapsing down so much if we use the cervix and then suture it to the uh, spine area. So there are more and more women that are having partial hysterectomies now. I know that other people, when they talk about a partial hysterectomy, they're talking about just removing the uterus and leaving the ovaries and tubes. But for me, a total hysterectomy means removal of the uterus. So total would be total removal. I understand that people have started, it's been used often enough that it's now an acceptable alternative definition. But again, be very careful when you hear people talk to make sure you know exactly what they're saying. And so when we have women that have pretty severe symptoms, putting them on 2 or 3 years of therapy makes perfect sense. Probably no more than 5 is recommended, although I have a couple of women that sign a release every year that they want to continue it. So you can do the estrogen either orally or transdermally, and it will preserve the bone density. So it's a great medicine for protecting the bones. Premarin, so-called because it comes from pregnant mare's urine, Prempro, and these are a combination estrogens. So they actually have types of E1, E2, and E3 in them. There's 3 types of estrogens. I'm not going to use the chemical names because I don't think that's particularly important to what the point we're trying to make. And this is one of the reasons that this type of estrogen supplementation seems to be less problematic for VTE than E2 only. So EEMT is actually a preparation which has testosterone in it. And so testosterone is often given to women who are perimenopausal because it will restore their sex drive and sometimes even has positive mental health effects. But so there's various preparations. When you get estrogen preparations, you can gain weight, you can have some discomfort abdominally. But most women tolerate it without much for side effects as long as the dose is not outrageous. Vaginal atrophy, years ago we used to call this atrophic vaginitis, but the newer term is vaginal atrophy. So basically it's just age-related changes where you have decreased secretions, vaginal dryness, and sometimes irritation and pain associated with that. And so a topical estrogen will work quite well and will make those things go away. Again, progestins should be added to any woman who has not had hysterectomy to prevent the probability of endometrial cancer. You can use medroxyprogesterone, which is usually given in pill form. Mirena is actually a good option as well because it does secrete progesterones continuously. There's not quite as much research on the use of Mirena for that, however. And again, medroxyprogesterone is 5 to 10 milligrams, does have some side effects. It will decrease bone density, but if you have them on an estrogen as well, it should offset. And the prometrium is basically the same kind of thing. And again, the couple of trials showed that Mirena worked well, but it does suggest that there probably should be more research. If a woman doesn't tolerate estrogens, there are some other non-hormonal type treatments, including SNRIs, SSRIs, clonidine, and gabapentin. The SSRIs and SNRIs are actually the first choice if you're not going to put a woman on hormones. They seem to show pretty good symptom reduction, but it's not great for women that have extreme symptoms. And obviously they have the usual side effects that those medicines would have. Clonidine is sometimes given as a patch, sometimes given as a pill. It is a centrally acting alpha agonist and therefore does decrease the blood pressure, slows the heart. It's used for lots of things, and this is yet another one. Unfortunately, there are substantial side effects in some women with dry mouth, dizziness, sedation, etc. And then the last option that we'll talk about today is gabapentin. So gabapentin was an anti-seizure medicine that we found had all sorts of other benefits. And we're not sure how it works with menopausal symptoms, but 300 and 900 milligrams in 3 divided doses or a single dose at bedtime. Unfortunately, gabapentin at higher doses does make people feel off, goofy, different, and so they tend to resist taking it at that dose, but that is one of the options. Something I don't have a slide on is topical estrogen preparations. Those have to be compounded in a compounding pharmacy, and so your options will be limited, although the compounding pharmacist will be of great help. And they can put in E1, E2, E3 combinations thereof, or possibly even some testosterone if the woman is interested in improving her libido. So this gets you started. Obviously, lots more to know, and I look forward to further discussions. Thanks.